Alright, hi guys, a very good evening to all of you and welcome to our part 2 of most expected MCQ series. And yesterday was the part 1 where we have discussed some of the very important topics in pharmacology. It was a 1 hour session. Likewise today as well we will be having a straight 1 hour session in which we will be covering some of the very important topics, including your general pharmacology and also antimicrobial. We also will have questions from other topics like ANS and central nervous system as well. So let me start this session very quickly, but I need a quick confirmation from you. If I'm clearly audible and visible, if everything is fine, please give me a quick confirmation in the comment section here. For all the students, those who are new, you can reply in this live chat option. There's a live chat option going on, and I think there is some issue going on, due to some technical reason, I believe. The notification is not being sent to the student, but anyway, those who are actually following the session, those who are actually following the groups, I have already shared this link in the different groups as well, the Telegram group of Unacademy and also on my Facebook pages as well. So for all the students those who are live, please give me a quick confirmation if I'm audible and visible to all of you guys. Everything is fine? Okay, thank you very much. So a couple of announcements that I'm having about the test calendar that we are having, the free NEET PG calendar on the platform, and all of you guys can take advantage of this. And I think today at 10 p.m. it was the image based question, mixed bag image based question, and all the other tests has already been conducted. And at any point of time, whenever you have to attend any test, like All India NEET PG mock test that will be conducted tomorrow 9 a.m., you can actually use the same code pharma10 to avail the offer, and also to unlock all this test, all these free courses you can actually unlock. All right. These are the different duration of the subscription that is present on the platform and the cost as well. So for the plus, where you will avail all the benefits of the Unacademy, iconic you will have Unacademy plus prep ladder both, and light subscription will be mainly the test series. Everything that is related to test series you will you can access from this light, so subject wise, topic wise test will be there. And MBBS subscription will be especially in this one you can watch all the first year lectures like anatomy, physiology, biochemistry. So it will be a very comprehensive course, like around 120-130 hours for each subject has been given. So it's like all the classes will be like medical college that you are actually attending, but with your favorite faculty that are there on the platform. This is the one that I was talking about. And for enrolling in this as well, you can use the same code pharma10 to avail a 10% off or to unlock multiple free courses as well. This was the light for test series. All right, PYQ is also live for all the plus subscribers. PYQ, where you will have at least 4 years of PYQ of different examination like NEET PG, AIIMS, and FMGE. So if you are one of the plus subscriber, you can take advantage of this and understand the mindset of the examiner, that what is the actual question that are being asked in the examination. Okay, for the plus learners, daily or practice papers are also live on the platform. So after every class you can actually practice some of the important MCQs. Okay, frequently volatile topics and also in emergency medicine, these are the a 10-day session that is being planned in the month of May, and I'll be covering some of the important topics in pharma as well. So 2 sessions will be there, each of which will be 2 hours. So total 4 hours we will be dedicating for this topic, frequently forgotten volatile topics. Okay, so I think after this we are ready and we can actually start this high yield MCQ session on this platform. And like usual, I'll be giving you one question and I'll be checking your responses here in the definitely Dr. PK. They all can join because of the syllabus is same for everyone. Definitely they can join. You yourself will realize, watch a couple of questions and then you will realize. Okay, so the first question that I'm having is this: 55-year-old male was started on tetracycline for urethritis. Which of the following agent is not preferred in this patient for prevention of GI irritation or ulcer formation? So with the ranitidine, they are telling if there is a risk of GI ulceration or GI related side effect, which drug you will not be preferring. Go ahead please. Ranitidine, pantoprazole, antacid, dexlansoprazole, what will you not prefer among all of them? Please go ahead. And all the students, those who are live, try participating in this. So I see most of you are marking D, some of you are also marking C. Very nice. D, okay, which is not preferred. Why will you not prefer D? Tavish, Paneer Selvam, KGB, Benedict, PK, all of you. Why will you not prefer? It's a proton pump inhibitor, and you see proton pump inhibitors can be added, for prevention of GI irritation or for gastritis related symptom you can add. So what is dexlansoprazole? It is just like pantoprazole, a proton pump inhibitor, but we are having antacids. We know antacids have aluminium and they also have magnesium. So these aluminium and magnesium that that can actually chelate the drug, and they will interfere in the absorption. As a matter of fact, these antacids are so notorious that they are usually contraindicated with many drugs, right? So these antacids are usually contraindicated with, let's say, ACE inhibitors. Yes, they are also contraindicated with thyroxine. Yes, they are also contraindicated with tetracycline. Yes, with many drugs they are actually contraindicated. There are some of the examples that I am referring to all of you guys. So do remember, antacid के साथ हम tetracycline को नहीं देते. It's always and always contraindicated. Okay, great. So C is the correct answer, not D. D, dexlansoprazole, same as pantoprazole, so it can be given, and H2 blocker, ranitidine, that can also be given. So that is a short and crisp explanation, because we have so many questions today to discuss. There's a 29-year-old patient was started on glycofulvin for dermatophytosis. Which of the following statement is false about this drug? About glycofulvin, which of the following statement is false? It can cause lupus-like syndrome. It's a potent enzyme inducer. Act by inhibiting synthesis of the ergosterol. It causes disulfiram-like reaction. Please go ahead, provide your answer. All of you, please try taking part. Even if you're thinking that you might get wrong, it doesn't matter. Okay, very nice. So 30-second time DG, but make sure that you are participating. So I'm getting mixed responses here. B, A, C. Okay, very nice. C, A, all right. So many of you are actually marking A and B and C. So mixed bag reaction are. Now first of all, what is glycofulvin? What is glycofulvin, guys? It's an antifungal drug. I think itna to sabko clear hai. It's an antifungal drug that is acting by inhibiting microtubule formation. So microtubule inhibitor, and this is your fungistatic in nature. This is fungistatic in nature. This does not act on the ergosterol. The drugs acting on the ergosterol are drugs like your amphotericin B. Example of this will be amphotericin B. Drugs like terbinafine, right? That is squalene epoxidase inhibitor, and also drugs like your azole. So these are interfering in the ergosterol synthesis. Okay, these glycofulvin is not interfering with the ergosterol synthesis. They are mainly microtubule inhibitor. Of course, antifungal drug glycofulvin is a very, very potent enzyme inducer, like glycofulvin, phenytoin, rifampicin, okay, barbiturates, DDT. These are all very, very potent enzyme inducer. Carbamazepine also. It can cause disulfiram reaction. Yes. Remember the mnemonic that I used to tell you, that in Government Medical College of Madhya Pradesh and Chhattisgarh, you will be getting disulfiram like reaction. So in that, this Government Medical College that we are having, it is G for glycofulvin only. Other drugs, if you wanted to revise quickly, griseofulvine, metronidazole, and C say we are having cephalosporin 3. That is C4T10, C4-mendose, C4-perazole, moxalactam, procarbazine, an anti-cancer drug, and chlorpropamide, a first generation sulfonylureas. So these are all drugs that are having disulfiram-like reaction by inhibiting the enzyme aldehyde dehydrogenase. So I hope all of you guys have got this, that why C is the correct answer here. And you have to choose a false. So this is a false statement. C is a false statement. That's why it's correct. And it can cause disulfiram. It's a potent enzyme disease. It can cause lupus-like syndrome, and also it can, serum sickness or lupus-like syndrome can be caused by this drug. Yes. And so C is the correct answer. I hope it is making sense to all of you. And now I will take the next one. So this is the microtubule inhibitor. Another case, a 60-year-old child started on antimicrobial agent by a quack in village. Later he complained of limping and difficulty in walking. The orthopedician diagnosed him to be a case of tendinitis. Which of the following agent might be the most likely cause of this tendinitis? Go ahead. So this is going to be a 1 hour long session. You guys just sit back, relax, and try to answer these. And even if you are going wrong, doesn't matter. Stay till the end of this session and try learning from each of this question, because every topic will be covered. Like for example, important points about griseofulvine I have covered. Likewise, for this drug as well will be covering in this question. So now students have started marking this D, B, C. Okay. There are some marking B, some are marking C, some are marking D. Okay, very good. Okay, doxycycline, erythromycin, very nice, very nice. Karthika is marking erythromycin, very good doctor, excellent. Dr. Tej is also marking C, erythromycin, excellent doctor, very nice. But sadly none of you are correct actually. Why is that so? You must have heard about a side effect known as your tendinitis and arthropathy. Limping हो रहा है ना, tendinitis and arthropathy. It can even cause development of rupture of the tendon. It can even cause tendon rupture. अब आपको समझ में आ रहा है कौन सा ये tendon rupture? Which class of drug most likely cause of this one? Tendon rupture, will it be associated with doxycycline, a drug that is mainly associated with teeth staining, bone growth abnormality, mainly in the pediatrics, also. So I think most of you got tricked by the age that okay, doxycycline, tetracycline है, but it causes bone growth abnormality, does not cause tendinitis and arthropathy. ठीक है, ये भी एक पॉइंट है आपको जो नोट करना है. ठीक है, tendinitis and arthropathy, it can even lead to tendon rupture. There will be other side effect as well, like for example it's a causing photosensitivity, QT prolongation. Multiple side effects are there with this fluoroquinolone as a class of drug that we have. So the only drug that we have among the given list which is a fluoroquinolone is ciprofloxacin, right? So why most of you fall in the trap of this? Because you thought okay, limping hoga to doxy hoga, but nahi, doxy mainly is associated with the problem like bone growth abnormality, teeth staining is the main important problem. Tendinitis, arthropathy, tendon rupture is mainly fluoroquinolone. Now there are many students in favor of erythromycin macrolides. Macrolide ka side effect, we don't have any such side effect like tendinitis, arthropathy, tendon rupture like that. It will be nausea, vomiting, it can even cause photosensitivity, and hepatotoxicity will be the other problem, hypersensitivity reaction could be the other problem, and autotoxicity could be a problem with macrolides. Autotoxicity is a known side effect. Cefotaxime does not cause, highly safer and highly preferred in the pediatric age group, does not cause this kind of side effect. Many students have given D, I can see here many of you have given D, so I hope all of you guys have seen this. Cefotaxime is not going to be the correct one. A patient on clopidogrel therapy, the operative intervention should be done. Best practice would be continue clopidogrel and delay the surgery for 5 to 7 days. Continue clopidogrel till 1 day before surgery. Start platelet infusion. Stop clopidogrel and postpone the surgery for a week. So I think all of you guys are already aware that this clopidogrel as a drug, guys, it is one of the ADP inhibitor. और ADP का एक रिसेप्टर होता है P2Y12 that is causing the platelet aggregation. Do you remember clopidogrel is a drug, it's a prodrug, and this prodrug is actually metabolized by a microsomal enzyme CYP2C19 to be active. So these two questions are very frequently asked. Their mechanism of action and also this metabolism, right? And this metabolism that we have is inhibited by your drug like omeprazole. That is why we are not giving this clopidogrel with the omeprazole. Now because it's an irreversible inhibitor, this clopidogrel that we are having, it's an irreversible inhibitor of P2Y12. Once it inhibits the P2Y12, the ADP inhibition will not allow the platelet activation, and definitely the effect will last for entire lifespan of the platelet, like at least 7 to 8 days. So if a person is on clopidogrel therapy, do not just push for, if it's a elective surgery, then we usually try to shift the patient to a shorter acting antiplatelet drug, and then we try to postpone the surgery. So continue the clopidogrel and delay the surgery. There is no point of continuing and delay. Either you stop and delay, that could be understood, or shift to a shorter acting antiplatelet drug like ticagrelor, and then you can delay the surgery. That could be understood. But continue bhi karna, delay karna, there is no point. Stop clopidogrel. No, stop clopidogrel. No, इस यहाँ पे till नहीं होगा. I thought there is a continue word. No. Stop clopidogrel 1 day before surgery. No. 1 day before surgery नहीं. कब stop करना है? At least a week prior to the surgery. It should be stopped at least a week prior to the surgery. Start platelet infusion and do what? So this is very incomplete kind of option. However, if the person is on aspirin therapy, we arrange the blood. If it's an emergency surgery, arrange the blood and then do the surgery. And if it's an elective surgery, then we try to stop and shift the patient to a safer or shorter acting antiplatelet, and then we postpone the surgery or reschedule the surgery after a week. So the best choice that I would go ahead with the D here. With most of you have got this correctly. In this one, most of you have got this correct. Next one. The anti-dyslipidemic drug Volani source and act by. Very easy. Inhibitor of ApoC3 synthesis, inhibitor of ApoB100, CETP inhibitor, MTP inhibitor. Pantoprazole, rabeprazole are safer. If you are going to talk about this one, omeprazole nahi denge, but PPI like pantoprazole, they are having less interaction. Rabeprazole, they have shown to have less interaction with the clopidogrel, therefore it can be given. Yesterday part 1 I have already uploaded in the group. I am sure all of you guys have got this. This part 2 as well I will be uploading in the group. At the end of the class I will upload the PDF in the group. Dixit Chauhan. I hope all of you guys have already got the part 1. And if not, then I will resend it again. Nikhil has got this, that's great. Okay, please go ahead, mark this question. Most of you are marking B. ApoB100 synthesis. Apo is MIPO. So the drug that is inhibiting this one is a MIPO-Merson. So I just ruled out your answer, that is B. ApoB100, all of you, Abdul Samad, Karthika, Benedict, Naved, मंदर, लवन्या, निखिल, मैंने रूल आउट कर दिया, वो तो है नहीं. ओके, नाउ पीके इज टेलिंग सी. CETP inhibitor actually FDA approved तो नहीं है, but we have one drug that is anacetrapib that have shown some good result. Anacetrapib, it is cholesterol ester transfer protein inhibitor, anacetrapib. So apart from niacin, this is the one drug that has shown to increase HDL level. Niacin is the one that increased the HDL level, but after that this is the one drug but not got FDA approval yet. Okay, next. अब बताइए. Karthika is telling D, MTP inhibitor. Okay, सो एमटीपी इनहिबिटर नेम इसका जो ड्रग का नाम है उसका नाम है लोमिटापाइड. व्हाट इज एमटीपी? व्हाट इज एमटीपी? एमटीपी इज माइक्रोसोमल ट्राइग्लिसराइड ट्रांसफर प्रोटीन इनहिबिटर. माइक्रोसोमल ट्राइग्लिसराइड ट्रांसफर प्रोटीन इनहिबिटर, दैट इज योर लोमिटापाइड. ओके, माइक्रोसोमल ट्राइग्लिसराइड ट्रांसफर प्रोटीन इनहिबिटर. मैंने इसको भी रूल आउट कर दिया. तो बचा क्या? इकलौता बचा ApoC3. नाउ वी ऑल नो दैट इन आवर बॉडी ट्राइग्लिसराइड इज ब्रोकन डाउन और आई वुड से मेटाबोलाइज्ड by an enzyme known as your lipoprotein lipase. Undoubtedly, lipoprotein lipase, the normal lipoprotein lipase, is causing degradation of this triglyceride. But the problem is, what they found out, that there is one protein which is synthesized in the liver, जिसका नाम है ApoC3. It is being synthesized in liver and it is having inhibitory effect over lipoprotein lipase. Can you guys see that if lipoprotein lipase is inhibited, what will happen to the level of triglyceride? It is very obvious, no, that the level of triglyceride will increase. So this ApoC3 is the bad guy here. ApoC3 is the bad guy. Therefore, we can inhibit ApoC3 by a drug known as your volanesorsen. So ये एक ऐसा विलन है, उसको आपको इनहिबिट करना है. Volani is the villain, bad guy, विलन है ना. Volanesorsen, विलन को इनहिबिट करना है. वोलानिसोर्सन, सो इसको इनहिबिट करना है. सो इफ यू इनहिबिट ApoC3, this inhibition of lipoprotein lipase will be gone, and of course this triglyceride normally can be broken down by the lipoprotein lipase. So this will also go actually. It's on YouTube, Dr. Arsh Gautam. It's on YouTube. Just इसी के आसपास आपको मिल जाएगा. इसी के नीचे आप स्क्रॉल डाउन करोगे, you can easily find Arsh Gautam. It's not on Unacademy. Part 1 is also here, and I have uploaded the PDF in the Telegram group. I will upload it today as well. So I think सारी बातें क्लियर हो गई यहाँ पे. Important anti-dyslipidemic drug. Now can you tell me guys, since we are talking about anti-dyslipidemic drug, which of the following is a PPAR alpha agonist? Because this PPAR alpha is also something to do with the lipoprotein lipase. PPAR alpha, pro-protein, PPAR alpha, not pro-protein, peroxisome proliferative activator receptor. The pro-protein वाला अलग है, PCSK9 है, that I will tell subsequently. Fibrates है ना. So peroxisome proliferative activator receptor alpha, these are all the fibrates, like bezafibrate, clofibrate, gemfibrozil. These are all fibrates, and these fibrates, they are going to act via nuclear receptor, and by acting via nuclear receptor, they will be actually increasing the transcription of an enzyme known as lipoprotein lipase, and this lipoprotein lipase will be causing triglyceride ka breakdown. So this is also a drug, or I would say the best drug for decreasing triglyceride level is going to be fibrates. Many drugs are there: clofibrate, fenofibrate, bezafibrate, gemfibrozil. These are all the fibrates. Let's take a very easy one. A 55-year-old patient was given an agent named torsemide for the diuresis. True statement about this agent. So he's taking torsemide, and you have to find out one true statement. What is torsemide? If you know, then definitely you can get the correct answer. Yes, Dr. Sukhbir, the answer to your question is yes. मतलब इतना भी न्यू नहीं है, पिछले 3 साल से मैं तो पढ़ा रहा हूँ. तो अगर आपने 18 में भी मेरी क्लास लगाई होगी, 17 में भी लगाई होगी, उस समय भी ये था, मतलब बुक में ही था आपके. इट हैज नॉट बीन टेकन फ्रॉम एनी रिसर्च आर्टिकल और एनीथिंग. इट इज टेकन फ्रॉम योर बुक ओनली, द यूजुअल बेसिक MBBS लेवल बुक. So you guys are marking actually C. It can cause hyperkalemia. Okay, very good. D. Some of you are marking A. Very nice, very nice. So as I can see that responses are coming mixed bag, but many students, Mannat is in favor of A, and she sounds very confident. Sukhbir is also A. So of course I think all of you guys are very well aware that this is actually a loop diuretics, and we all know that loop diuretic, what is the site? Loop diuretic act by blocking NaK2Cl, sodium potassium 2 chloride inhibitor at the thick ascending limb of loop of Henle. thick ascending limb of loop of Henle, it will be acting. Another thing that they say, that once they inhibit this co-transportation of NaK2Cl, of course there will be loss of sodium, there will be loss of potassium, there will be loss of this as well. So everything will be lost. So it will not cause hyperkalemia. Now it will be causing hypokalemia. In addition to that, remember, it also causes loss of calcium. Loop diuretics also causes loss of calcium, and because of this particular reason, it is a diuretic that is highly preferred in acute hypercalcemia patient. ठीक है? It does not cause hypercalcemia. They cause loss of calcium, so ultimately the level of calcium will be decreased. So if there is a higher dose or if there is a toxicity, definitely it will lead to hypo, because they are losing calcium. They will not cause hypercalcemia. In fact, they are used in the management of the hypercalcemia. They do not cause hyperkalemia. They will be causing hypokalemia, and they do not inhibit uric acid excretion. This property of uric acid excretion inhibition, it is associated with your thiazides. So if you see preferred in hypercalcemia, that is the correct answer here. So torsemide is a very simple question here. That is loop diuretics. Okay, making sense? And because it is actually increasing the calcium excretion, so more and more calcium will be passing through the renal parenchyma, renal tissue, and therefore they are going to be contraindicated in a renal stone patient. That is another question. When more and more calcium will be passing through that, there are chances that this calcium might get saturated and it can increase the size of renal stone. Therefore they are contraindicated in renal stone patients. Okay, A is the correct one. Okay, this recently approved drug Selexipag for pulmonary artery hypertension acts by. So don't only not only is this drug is important, but everything around this drug, every option in this question is important. So you have to know each of these options so that you can rule out. Go ahead, please. Yes, आप सबको भी ईद मुबारक. And it has one, I think 2 more days, I guess. It will be too early to say Eid Mubarak to all of you guys, and don't worry, I will be live. I might be live even on the day evening of the Eid as well, to say you all Eid Mubarak, and also to discuss a couple of MCQs on the platform. So since exam is near, I do not want to take any break here. I will try to do more MCQs, at least. Even if I am coming for at least 1 hour, that will be good. In the evening I might be live with you. We can say Eid Mubarak then. Alright, so very good. So Mannat is studying okay, phosphodiesterase. Mannat sounds very, very confident, and she has made multiple C's. Okay. चलिए सबसे पहले बात कर लेते हैं सेलेक्सीपैग है ना. It's actually a prostacyclin receptor agonist, PAG, prostacyclin agonist, receptor agonist, है ना. So correct answer first of all, मन्नत ध्यान दीजिएगा, it's a prostacyclin receptor agonist. First I will be telling you this. Now why why C is not the answer? First of all, in pulmonary artery hypertension we do use phosphodiesterase 5 inhibitor. There is no doubt about that. And the drugs here will be drug like sildenafil. Sildenafil, Selexipag अलग अलग है ना. Sildenafil is your the same favorite blue pill है ना. Sildenafil, Tadalafil, Vardenafil है ना. So these are actually phosphodiesterase 5 inhibitor. Another question in 2021 it was asked, which is the longest acting. So this Tadalafil, it is lasting for around 18 hours, so it is the longest acting compared to sildenafil, and vardenafil, they are lasting in around 6 hours. Okay, so sildenafil that we have here is the drug of choice in erectile dysfunction, but do remember it was not approved for erectile dysfunction first. This was the drug that was mainly given for the pulmonary artery hypertension, but later on when they found that all the patients of the pulmonary artery hypertension are getting benefit somewhere else as well, then after multiple randomized control trial they found okay, this drug can be given to this patient as well. So now for the pulmonary artery hypertension we have a different drug of choice, like endothelin receptor antagonist है ना, ambrisentan. This is the drug of choice and current recommendation के according they say give this ambrisentan endothelin A receptor antagonist sitaxanthan. These are the endothelin A antagonists. Give this endothelin A antagonist in a fixed dose combination with the sildenafil. So it's available. Ambrisentan or sildenafil. So we use sildenafil का 20 milligram also. But for erectile dysfunction के लिए आप लेते हैं तो उसमें डोज अलग होता है 50 and 100 होता है. But for this patient it will be 20, है ना? So fixed dose combination में it is also highly effective. Direct activator of nitric oxide or direct sensitizer of nitric oxide will be much better term. Sensitizer of the nitric oxide. So the sensitizer of nitric oxide will be a drug that is your Riociguat. So this is not only sensitizer of nitric oxide, plus it is also a soluble guanylyl cyclase activator. So ये उसका भी activator है, soluble guanylyl cyclase activator. Therefore the level of the CEMP is actually increased. Okay, phosphodiesterase 5 inhibitor भी मैंने बता दिया. अच्छा, the grade 4 pulmonary artery hypertension or advanced stage of pulmonary artery hypertension, here we use the PGI2 analog. What are the PGI2 analog? Drugs like your treprostinil, ठीक है, drugs like your treprostinil, epoprostenol, eloprost. So these are either available by the IV route or inhalational route, है ना, IV, inhalational, subcutaneous, है ना, they are also available by the IV route, है ना, inhalational route. So treprostinil, eloprost, epoprostenol, these are the best drug in fact for pulmonary artery hypertension. Cost is the main problem. That's why we are using this ambrisentan, sitaxanthan. These are the drug of choice actually. So mainly these are preferred in grade 2 and 3 pulmonary artery hypertension. In grade 1 pharmacotherapy is usually not required. But if you want to start, we always start with this endothelin receptor antagonist. Then in NEET PG I saw there was another question that inhaled nitric oxide is used. So inhaled nitric oxide you can use. You can also use diuretics. These are the other drugs that can be used for the management of the pulmonary artery hypertension. So inhaled nitric oxide and in other drugs in the pulmonary artery hypertension का management में inhaled nitric oxide, diuretics you can use for the management like loop diuretics you can use. Then you can even use certain anticoagulants as well. If there is in situ thrombosis that is causing possibly this pulmonary artery hypertension, then we can use this as well. Calcium channel blocker, especially the dihydropyridines, drugs like your amlodipine, nifedipine, they can also be used if the vasoreactive test is positive. So not only these 3-4 class but the other classes of drugs that I have told you here can also be used. So एक बार में 2 मिनट में मैंने पूरी pulmonary artery hypertension आपको पढ़ा दी, ठीक है. So if you have read from your notes, definitely you revised the important drugs or important treatment for the pulmonary artery hypertension as well. Okay, next one. What's resicadotril? Let's go ahead please with the next question. All of you try, even if it is going wrong, keep trying. And the more you try, the more you learn the art of control guessing. So you guys are marking actually B. Encapsulinase inhibitor. Pranav is in favor of C, that is neutral endopeptidase inhibitor. Very good. Other students also please take part. Now why this term little bit very closer options are there. The terms are little confusing here. Like you must have heard about certain drugs like Icadotril, Sacubitril. So those are neutral endopeptidase inhibitors. They are mainly used in the pulmonary artery hypertension. Icadotril and Sacubitril. So C cannot be the answer, as I have already clarified. मन्नत, कार्ति, महालक्ष्मी, ट्रिल नाम होने से है ना वो सारे न्यूट्रल एंडोपेप्टिडेज इनहिबिटर नहीं होते हैं. And what is neutral endopeптidase is the same as neprilysin. So we all know that for the heart failure we use BNP analog, and BNP, brain derived natriuretic peptide, it causes diuresis. It's also a vasodilator. So diuresis and vasodilator are the property, but the problem is, like any other peptide, it is also metabolized by an enzyme NEP, also given the name as a neprilysin. Neprilysin is same as NEP, neutral endopeptidase, that is going to increase the metabolism. So for heart failure we can use one BNP analog, that is nasiritide. Well and good. And neutral endopeptidase inhibitor we can use, that is your icardotril and sacubitril. Icardotril and sacubitril are the neutral endopeptidase inhibitor. So correct answer, I think most of you have got this already. Enkephalinase inhibitor. We all know that in our body we are having endogenous opioid like enkephalin. And do you know what is the function of this enkephalin? It actually causes constipation. Like an endogenous opioid, definitely it will be causing constipation. It also decreases the secretion. Decreases the secretion and causes constipation. Enkephalin, it's an endogenous opioid, but the problem is endogenous hai, so we have an endogenous enzyme as well by the name of your enkephalinase. Enkephalinase is going to metabolize this particular enkephalin, endogenous opioid, and our drug that we are having by the name of resicardotril, it is acting by inhibiting this one only. Resicardotril, it acts by inhibiting enkephalin. Okay, it has enkephalinase. So once they inhibit enkephalinase, the availability of enkephalin will be increased, and rest of the thing you can easily understand. If enkephalin is increased, the constipation or the diarrhea can be controlled. So mainly in the secretory diarrhea we are using resicardotril. So don't be confused with the icardotril, sacubitril and resicardotril. Similar sounding name है, but definitely बहुत अंतर है. एक हार्ट फेलियर में यूज कर रहे हैं और एक डायरिया में यूज कर रहे हैं. कोई कोरिलेशन नहीं दोनों में, है ना. These are used in heart failure, है ना. Chemoreceptor trigger zone inhibitor are same as drugs like 5-HT3 antagonist like ondansetron and all. Okay, so B is the correct answer here. Agent not used in sequential therapy. So first you have to know what is sequential therapy, and then you will be able to reply the answer. Zaid in favor of A, PK in favor of C. Very good. Tinidazole, very nice, very nice. Do you guys know where do we use sequential therapy? For which purpose it is approved? Sequential therapy. पहले बता दीजिए. Karthi is in favor of Clarithrol. For which condition are we using sequential? पहले ये बात बता दीजिए. Simple question. In the H. pylori therapy, we know in the H. pylori therapy, very good. Some of you are marking correctly. In H. pylori therapy, we are having some therapies like your triple therapy. We are also having your quadruple therapy, and we are having sequential therapy. Now the name has been given on the basis of the antibiotic usage, or I would say the total number of drug usage. So in the triple therapy, we are using 3 drugs. Quadruple में we are using 4 drugs, and sequential में we are using antibiotic in a sequence. So since the question is asking about sequential therapy, I will just focus on this one. So they are telling that give the antibiotics in the sequence, and from day 1 to day 5 you are supposed to continue the PPI, and along with the PPI you give amoxicillin. They are telling why giving all the antibiotics together, give them in sequence. And amoxicillin 1 gram you are supposed to give twice daily. Then from day 6 to 10 you are supposed to give proton pump inhibitor. Along with the proton pump inhibitors, you will be adding the most effective macrolide or most sensitive macrolide, clarithromycin and metronidazole. However, if metronidazole is not there or if it's ineffective, You can even use tinidazole as well. So metronidazole की जगह पे आप tinidazole भी use कर सकते हैं. Now this colloidal bismuth subsalicylate that we have, it is mainly used in a quadruple therapy. It is mainly utilized in the quadruple therapy, where we use tetracycline, PPI, and metronidazole and one of the colloidal bismuth subsalicylate, one of the ulcer protector. So I hope this is making sense to all of you, that we do not use colloidal bismuth compound in the sequential therapy, but in the quadruple we can use. We also do not use them in the triple. So quickly, can you tell me triple में क्या use करते हैं? We use 2 antibiotics and we gave them together, 2 antibiotics out of CAM, CAM and plus PPI. So मैं mnemonic हमेशा ये बताता हूँ, CAM, CAMP, CAMP, CAMP stand for your clarithromycin, amoxicillin and your metronidazole, है कि नहीं? 3 हो गए. Out of these 3, any 2 you will be taking, 2 antibiotics out of the 3 and 1 PPI. So 2 antibiotics plus 1 PPI will be total 3 drugs. In the quadruple, as I told you already, you can use triple के साथ colloidal bismuth subsalicylate, or you can even give tetracycline based therapy. So what is tetracycline based therapy? You can give tetracycline, you can give metronidazole, you can give colloidal bismuth subsalicylate, and fourth one will be PPI. So that is your proton pump inhibitor. So I hope all of you guys have seen NH pylori therapy. Again, in one question we have quickly revised. Next one, doxylamine is used for, very very simple question yet important. डॉक्सिलामिन यूज फॉर सी सिकनेस, मॉर्निंग सिकनेस, मोशन सिकनेस, माउंटेन सिकनेस. कहाँ पे यूज करेंगे? आई थिंक सबको पता है डॉक्सिलामिन डॉक्सीनेट के नाम से आता है. इट इज वेरी कॉमनली यूज ड्रग इन द पेशेंट विद गिवनिंग सिकनेस. एंड हु आर द कैंडिडेट ऑफ मॉर्निंग सिकनेस गाइस? मॉर्निंग सिकनेस फर्स्ट ट्राइमेस्टर प्रेगनेंसी में जो अर्ली मॉर्निंग नॉसिया एंड वॉमिटिंग होता है, एंड डॉक्सिलामिन यूजुअली गिवन with vitamin B6, pyridoxine के साथ देते हैं. I think we all know that for the mountain sickness we use carbonic anhydrase inhibitor as the drug of choice. For motion sickness, what do we use? What do we use for motion sickness? Hyoscine, scopolamine, hyoscine or scopolamine, or you can even use another first line drug, that is promethazine. Is the other drug that is preferred. It's also among the first line drug. Okay, which of the following drug combination is preferred together? The drug combination that is preferred together: 6-mercaptopurine, allopurinol. कॉन्सेप्चुअल है, ध्यान से मारिएगा. क्लोपिडोग्रेल, ओमेप्राजोल, स्टैवुडिन, ज़िडोबुडिन, एस्पिरिन एंड रेनिटिडिन. Which of these can you give together? So Sachin is saying I will be giving B together. Okay. Others are saying I will be giving D together. Very nice. Other students also please take part. Okay, so I think now most of you are talking about D. Very good. Now can we know why can't we give 6-mercaptopurine allopurinol? Because allopurinol is a xanthine oxidase inhibitor and 6-mercaptopurine is one of the allopurin hypoxanthine analog. So hypoxanthine analog is actually metabolized by the same enzyme, and therefore the risk of toxicity of 6-mercaptopurine is going to increase with the allopurinol. So ideally don't give, or if you have to give, you decrease the dose of 6-mercaptopurine by 75%. So earlier if you were giving 100, give with them only 25. You have decreased by 75. So 75 को कम कर दीजिए. ठीक है. Clopidogrel, omeprazole. I think we all know that omeprazole is a potent inhibitor of the CYP2C19, and they will not allow the activation of clopidogrel, so we should not give them. Stavudine, zidovudine, we should remember that zidovudine that we are having at a drug, it inhibits intracellular phosphorylation. All the NRTI require phosphorylation for their activation, intracellular phosphorylation of the stavudine, therefore this stavudine will not be activated. Both are NRTI, वो समझ गया, both of them are thymidine analog, वो भी बात सही है ना, similar toxicity हो सकती है, वो भी सही है, but the one of the very important reason is zidovudine is having inhibitory effect over the activation of stavudine. So कई बार लोगों को लगता है अच्छा दो हैं, we can give two NRTIs by the way together, there is no such rule that we cannot give two NRTIs together, like oftentimes we add NRTI by the ritonavir with most of the nucleoside reverse transcriptase ritonavir is a protease inhibitor, we can add ritonavir as well, but two of these NRTI can be given together, na? So sometimes we give two NRTI as well in the therapy. So when we go to the rule, we are having we have to take 3 drugs from 2 different classes. So 3 drugs from 2 different classes, so we take 2 NRTI and 1 NNRTI, or we can take one from each, one NRTI, NNRTI protease inhibitor, and so 2 drugs can be taken, but these 2 cannot be given because zidovudine inhibits the intracellular phosphorylation of the stavudine. A point to remember that all the NRTI, nucleoside reverse transcriptase inhibitor, it is actually requiring phosphorylation to be converted to nucleotide reverse transcriptase inhibitor, and this is going to be the active form, and this will be requiring phosphorylation. But this is not true with the NNRTI. NNRTI does not require phosphorylation, but nucleoside they require phosphorylation for their activation, है ना? So नहीं देंगे. Aspirin के साथ ranitidine it can be given. Aspirin is a known drug to cause gastritis, known drug to increase the risk of peptic ulcer disease, and H2 blocker definitely is a drug that can be used. There is no such contraindication with the aspirin. Okay. So I hope D is the correct answer, where most of you have got this. Most common side effect of antiarrhythmic drug amiodarone. Go ahead, please. Amiodarone क्या side effect करेगा? Most common. In fact, if I am not wrong, all the side effect can be caused by amiodarone. It's one of the drug from the class 3 antiarrhythmic drug. It's one of the drug from class 3 antiarrhythmics. What is the most common side effect? Some of you are telling B. Pulmonary fibrosis बहुत common नहीं है. देखिए पढ़ते हैं हम सब लोग हैं. Interstitial lung disease, pulmonary fibrosis, that is fine, but not very common. Zaid in favor of A. Most common side effect actually is thyroid abnormality. Now amiodarone, remember, as a drug, amiodarone, point to remember that it actually iodine इसके नाम में ही है, so they actually contain iodine. That is one point. And once they contain iodine, this iodine will increase the thyroid hormone synthesis, so they can increase the risk of hyperthyroidism. Not only that this amiodarone, it also inhibits peripheral conversion of T4 to T3. T4 to T3 conversion is inhibited by the same drug, that is your amiodarone. So now if that is the case, it can actually cause hypothyroidism, है कि नहीं? So there is hypo risk. So at one end I am telling you hyper, and now I am telling you hypothyroidism. So actually both of them could be a cause. Some patient can present hyper, some patient can present with the hypo. Okay, hypo दोनों के साथ patient present हो सकता है. तो amiodarone के साथ thyroid abnormality happens to be the most common side effect. Optic neuritis will be one of the side effects leading to optic side effect. Hepatotoxicity, of course, a common, but most common thyroid. Okay, which angiotensin receptor blocker has additional thromboxane A2 inhibiting property? Go ahead, please. Very good. Noor is studying A is very common. That's correct actually. Sushma is in favor of A. So we all know, I think we can go ahead here with the answer of the Sushma, that low sartan, it will lower down everything. Low sartan के बारे में क्या बोलते हैं? हर चीज low है. That means T half-life is the shortest, 3 to 4 hours. So lowest T half-life. Then losartan also lower down the uric acid level because of their uricosuric property. Losartan also lower down the LDL level. Losartan is also a drug that lower down a glucose level as well because of its additional property of the PPAR gamma agonistic property. Now this PPAR gamma agonistic property is seen with 3 drugs: T, that is telmisartan, most common; irbesartan, next in the common; and losartan, next in the common. So TIL, these are the 3 drugs. So of course by causing PPAR gamma they can also lower down the glucose level as well. So losartan के बारे में आपको बताया, thromboxane A2 inhibiting property है. So एक और लो वाली बात लिख लीजिए, of course that they are going to decrease the platelet aggregation because of the thromboxane A2 inhibiting property. Thromboxane A2 is a prostaglandin. Thromboxane A2 is a prostaglandin that causes aggregation of the platelet and also causes vasoconstriction. Okay, so once you see that this is having thromboxane A2 inhibiting property, the platelet aggregation will be reduced. Telmisartan, as I told you, it's a important drug having PPAR gamma agonistic property, therefore preferred in diabetic. Candesartan, it's a drug that is preferred for prophylaxis in migraine. Can also be used in hypertension, but preferred drug for migraine. Okay, which of the following drugs should be contraindicated in patient with a vasospastic angina? The drug that should be contraindicated. Go ahead, please. We are about to finish. 2-3 more questions and then we'll be done. This drug should be contraindicated in vasospastic angina: propranolol, nifedipine, both or none. Okay, A, B, C. Now we all know in the vasospastic angina, the coronaries will be in the vasospasm. The coronaries are usually going to be in the vasospasm. This vasospasm may be alpha 1 mediated vasospasm. Could be alpha 1 mediated vasoconstriction. Now if I am going to give propranolol, it's a non-selective beta blocker, guys. And when we give non-selective beta blocker, what will be the outcome? If I give a non-selective beta blocker, see, beta 1 definitely will control the heart rate, but beta 2, the one that was mainly present on the blood vessel, if it is gone, that was causing relaxation, definitely the alpha 1 mediated tone will increase further. So propranolol actually can increase the risk of vasoconstriction. Nifedipine is the DHPs. They are actually going to cause vasodilatation that will cause fall in the blood pressure. Any fall in the blood pressure will induce reflex action like your reflex tachycardia, right? A patient of angina, the myocardium is already gasping for oxygen and now you are inducing a tachycardia, reflex tachycardia. How justified is that? Not justified at all. So non-selective beta blockers, nifedipine, they both are actually contraindicated. As a matter of fact, they say beta blocker should be avoided as much as we can, but selective ones with the vasodilating property are something that is safer side, like carvedilol, labetalol, nebivolol, celiprolol. These are on the safer side. ठीक है? So propranolol non-selective है, इसलिए उसको नहीं देंगे. Making sense to all of you? So C is the correct answer. Ugi. C is the correct answer. Very nice. So I'll give you the next one. 2-3 more question. Which of the following agent is preferred for hypothyroid state mixed edema coma? For mixed edema coma, which of the following drug will you be using? T3, T4, methimazole, propranolol. We are about to finish. Students are in favor of A. Other students also please try. Abdul Salam in favor of B. Sachin is in favor of C. Very good, very good. Mannat Jan has given a Answer: only condition in which T3 is used is okay. Very good, very good. Directly, very nice, very nice. So I think most of you are actually getting correct here. See, T4 is actually longer acting one. They are long acting, less potent as compared to T3, which is more potent. Short acting and fast acting. T3 is mainly preferred in emergency condition, in hypothyroid emergency. Now some of you, those who are thinking about C or D, first of all, methimazole is an anti-thyroid drug. Methimazole is an anti-thyroid drug. It's one of the thyroid peroxidase inhibitor. How can you give anti-thyroid drug in a hypothyroid case? मेरे सामने कई ऐसे लोग आए हैं, द पेशेंट एक्चुअली प्रेजेंटिंग विद अ थायराइड, है ना, पेशेंट को एक्चुअली प्रॉब्लम है. फॉर एग्जाम्पल, देयर इज अ हाइपोथायरॉयडिज्म एंड यू आर सपोज टू सप्लीमेंट T4 on the OPD basis. We'll be using T4 only, जो एल्ट्रोक्सिन थायरोनॉम हम लेते हैं अगर हाइपोथायरॉइड पेशेंट है. बट आई हैव सीन ड्यू टू सम मिस्टेक, है ना, द पेशेंट इज यूजुअली ऑन द कार्बिमाजोल मेथिमाजोल, है ना, 5 मिलीग्राम कार्बिमाजोल मेथिमाजोल पे. सो दैट इज अ वेरी रॉन्ग प्रैक्टिस, है ना. हाइपोथायरॉइड केस है, उसमें आप एंटी थायरॉइड ड्रग कैसे दोगे? वो तो वर्सन कर देगा ना. सो इट विल बी यूटिलाइज्ड इन हाइपरथायरॉइडिज्म. प्रोप्रानोलॉल इज अ ड्रग that is also having property that it can inhibit peripheral T4 to T3, propranolol. So that is why it is also preferred in the thyroid storm as well. Hyperthyroid condition, hypothyroid emergency like thyroid storm में इसको use करेंगे. And hypothyroid emergency, the only use of T3 is in this condition. Mixed edema coma is an emergency condition. We need a faster acting. Yes, Arsh, we can say that, है ना. Okay, a 33-year-old patient, a female, on anti-thyroid drug carbimazole. Okay. On next visit, she reported to physician that she is pregnant. This maternal carbimazole intake is commonly associated with all the teratogenic effect except go ahead please. Which of the following okay, so most of you are marking B. काफी क्लोज ऑप्शन है. Methimazole causes scalp defect. Aruna Devi, are you asking or telling? See, this is an anti-thyroid drug, carbimazole. Carbimazole is a pro-drug of methimazole only. What is carbimazole? It's a pro-drug of methimazole only. So the effect of carbimazole, methimazole in the pregnancy will be same. They are the thyroid peroxidase inhibitor. Effect will be same. So I think that clarified your doubt, Aruna Devi. Now, if there's an anti-thyroid drug that is given to the mother, this anti-thyroid drug can even show effect in the fetus as well. So fetal may, if you give anti-thyroid drug, what will be the outcome? Will there be fetal goiter, yes or no? So one of the problem that you can get to see here, it will be fetal goiter. ठीक है, fetal goiter. They can even lead to aplasia cutis. Aplasia cutis, where there is a scalp defect. They can even lead to your choanal atresia, a condition which is usually taught in ENT as well. There is a nasobuccal membrane between nose and nasopharyngeal area. So choanal atresia. It can even lead to your esophageal atresia and scalp defect. So what is this scalp defect? It is same as aplasia cutis. And a scalp defect. So AIIMS में already image दिखा के पूछ भी चुका है which drug can cause this. So you can remember very easily by the mnemonic FACES. FACES is a very simple mnemonic: fetal goiter, aplasia cutis, choanal atresia, esophageal and scalp defect. Cleft lip and palate associated usually with the anti-epileptic drug, like let's say phenytoin, very commonly associated. Okay, and this explains the fact that these drugs like methimazole, carbimazole, they are usually a category X drug. They are category X drug in the first trimester in pregnancy. No matter what happens, do not give them in the first trimester. So if they are going to ask you what is the anti-thyroid drug of choice in pregnancy, anti-thyroid drug of choice in pregnancy depends when the patient is coming. If the patient is coming in the first trimester, then P for pregnancy, P for propylthiouracil. Then in the second and third trimester, when the organogenesis is done, then you can give the methimazole or carbimazole you can give. Alright. Lithium can even lead to cleft lip and palate. Many drugs are there that can lead to cleft lip and palate. Valproate can cause, carbamazepine can cause, phenytoin can cause, lithium can cause, ACE inhibitors can cause. Many drugs are there that can cause. Alright. So that will be your B. A patient with the colorectal cancer was started on chemotherapeutic agent. Later, after looking at the blood profile, he was also started on filgrastim. So he is on a chemotherapeutic agent. Later, he was started filgrastim. This agent is used for neutrophilia, anemia, polycythemia, neutropenia. I think it's a pretty simple one, not a very difficult one. Go ahead, please. Alright, so I think most of you are getting it very correct. So filgrastim, what is filgrastim, guys? It's one of the granulocyte colony stimulating factor. Mainly it is going to increase the level of granulocyte. So for the treatment of neutropenia, so this could be congenital neutropenia, this could be chemo induced neutropenia, either congenital neutropenia में भी आप इनको use कर सकते हैं, chemo induced neutropenia. Now in USMLE I have seen there was this question, why are you adding this? Is it going, option A, it is having anti-cancer effect and it is going to improve the platelet count, or it is going to prevent the systemic. So the purpose for giving them to prevent the systemic infection. To prevent the systemic infection. Systemic infection से बचने के लिए. ठीक है. Not for polycythemia, polycythemia के लिए नहीं, neutropenia के लिए. D is the correct answer. Neutropenia is the D is the correct answer for this one. True about gemfibrozil. I think I have already taught you this a couple of minutes ago. PPAR gamma agonist, increased risk of bladder cancer. PPAR alpha agonist, A and C both. अर्श गुप्ता इज अर्श गौतम आस्किंग डाब का पानी सर एक बार. समझा नहीं मैं आपकी बात को. व्हाट यू ट्राइंग टू से? अर्श, व्हाट आर यू ट्राइंग टू से? डेबिगेट्रन, दबा के दारू. डेबिगेट्रन टॉक्सिसिटी में यू हैव टू टेक इदारुसिजुमाब या डैब वाटर. डैब वाटर इज टेकन ओरली. डैब वाटर. सो डेबिगेट्रन इज द वन डायरेक्ट थ्रोम्बिन इनहिबिटर दैट इज टेकन बाय द ओरल रूट. और दबा के दारू इसलिए बोलता हूँ बिकॉज दाबिगेट्रन में हम लेते हैं इदारुसिजुमाब एज ए एंटीडोट, है ना डॉक्टर अर्श. सो ये भी काफ़ी कंफ्यूजिंग है. Many students are having different answer, but I think I have already clarified these are the 5 rates, है ना. इतना difficult नहीं है, 5 rates है ना. And this is going to PPAR alpha agonist. PPAR gamma and this one, they both are associated with a single drug, that is pioglitazone. Pioglitazone is the one PPAR gamma agonist, है ना. We are having others like rosiglitazone, but they are not used. So A and C तो हो ही नहीं सकता. Okay, last question for the day. A patient was started on second line anti-tubercular agent bedaquiline. True statement about this drug is? Go ahead please. Bedaquiline. It has low volume distribution, so large loading dose is given. It is highly effective in TDR, total drug resistant TB. It is given throughout the course of therapy and it can cause QT prolongation. बोथ पीपीए और अल्फा ये हर कंट्री में अप्रूव नहीं हुआ है. सम कंट्रीज में अप्रूव हुआ है एलिग्लिटाजार एंड सेरोग्लिटाजार. नॉट अप्रूव्ड बाय एफडीए yet. ठीक है. In some countries yes, like in Japan and all, PPR alpha and gamma agonist, they are being marketed. Aliglitazar, seroglitazar, and there are many drugs in the pipeline as well, about to come maybe. So I think most of you are marking B. See, total drug resistant में तो ये effective नहीं होगा ना. Total में तो सब कुछ resistant होता है. Name itself is total drug resistant. So first line, second line, everything is resistant. So we just try to give the palliative therapy for the patient, है ना, because mortality उसमें तो 100% होती है. ठीक है. Given throughout the course of therapy, no. Bedaquiline, if you are talking about the course of therapy, even if you are going to use, you know, a 9 to 12 month वाला regimen में, 9 to 12 month वाला regimen में, so we use only for the first 6 month, है ना, or I would say first 24 week के लिए ही use करते हैं. They are cardiotoxic agent. In that, for the first 2 week you are supposed to give your patient 400 milligram per day, and on the next 22 week you are supposed to give 200 milligram thrice per week. 200 milligram thrice per week. तो ये इनका डोजिंग होता है. Bedaquiline, they are not given throughout, and they are having high volume distribution. Come on, they have high volume distribution. In fact, the volume distribution is so high that if you stop the drug today, the drug can be found in the plasma, and at least 5.5 months, even after stopping the drug. Okay? So they have high volume distribution. MDR में effective, highly effective drug. In fact, इनके multiple regimen available हैं, जिसको बोलते हैं B-Pol regimen available हैं. और एक मैंने निमोनिक आपको बताया होगा क्लास में, अगर आपने सुना होगा तो बेक्लेप. बेक्लेप इज द वन दैट इज 9 to 12 month वाला, है ना. देन फॉर द 18 month वाले में ऑल्सो वी आर यूजिंग, है ना, जो LLB है, दैट इज लिवोफ्लॉक्सिन, लाइनोजोनेट एंड बेडाक्विलिन, है ना. इन दैट ऑल्सो वी गिव इट फॉर द फर्स्ट 6 month ओनली. LLB प्लस क्लोफाजिमीन, है ना. सो वी गिव एटलीस्ट 4 drugs in intensive phase. So this is only given till the, in 18 month वाले में for the first 6 month only we give, and then we stop. ठीक है. Can a NEET UG student watch? I don't think, doctor, I don't think, Rohit, that you will be in a position to understand what is bedaquiline, what is volume distribution, and what is drug resistant TB. So it's better, I don't think so. I don't think so. Sessions are for premium, doctor. ऐसा नहीं है. ठीक है. सेकेंड ईयर में है तो डेफिनेटली सेकेंड ईयर में है. नीट यूजी के, नीट यूजी में अगर है, मतलब एमबीबीएस में एंट्री नहीं लिया तो आपको तो कुछ समझ में ही नहीं आएगा ना. कम ऑन. एंड सेकेंड ईयर में है, थर्ड ईयर में है, इंटर्न है, INICT के लिए है, नीट पीजी के लिए, डेफिनेटली इट्स गोइंग टू बी इफेक्टिव. ओके. सो कैन कॉज QT प्रोलॉन्गेशन, दैट्स वन ऑफ द वेरी वेरी इंपॉर्टेंट साइड इफेक्ट, है ना. दे आर कार्डियोटॉक्सिक ड्रग. ठीक है. दे आर कार्डियोटॉक्सिक ड्रग. ओके, सॉरी. सो आई एम हैविंग वन लास्ट क्वेश्चन. एक और क्वेश्चन रह गया. लास्ट क्वेश्चन ही कर लेते हैं, एंड देन उसके बाद से विल कॉल इट ए नाइट हियर. आई थिंक काफ़ी ज़्यादा टाइम हो गया. विच ऑफ द फॉलोइंग इज रिसेंटली अप्रूव्ड एजेंट फॉर डायबिटीज मेलाइटिस? सो ये आसान सा है, कोई बात नहीं. अच्छा लग रहा है तो देखते रहो, कोई दिक्कत नहीं. बताइए, विच ऑफ द फॉलोइंग रिसेंटली अप्रूव्ड ड्रग फॉर डायबिटीज मेलाइटिस? सो डायबिटीज मेलाइटिस में वी हैव मल्टीपल ड्रग्स, है ना. वी ऑल नो, स्टार्टिंग फ्रॉम द वेरी बेसिक लाइक इंसुलिन, मेटफॉर्मिन, सल्फोनाइल, यूरियाज, है ना. देन यू आर हैविंग SGLT2 इनहिबिटर्स, है ना. देन यू हैव अल्फा ग्लूकोसिडेज इनहिबिटर, यू आर हैविंग GLP-1 एनालॉग, यू आर हैविंग DPP-4 इनहिबिटर. सारे ड्रग हैं लाइन से, बट अब पूछ रहे न्यू कौन से हैं. मल्टीपल ड्रग्स आर देयर, राइट. So C, D, C, multiple students are marking different answer. So first of all, that bromocriptine is actually D2 receptor agonist. It's also approved for the diabetes mellitus. Hydrochlorothiazide is itself associated with hyperglycemia. They are associated with increased level of glucose. So they are actually avoided, or I would say, contraindicated in diabetes. You should not give them thiazide that is in diabetes. Colesevelam also, it's one of the bile acid sequestrant. So they are actually also approved to be used in diabetes mellitus. It's an approved drug. So A and C both is the correct answer here. And A and C, both of them are the correct answer for this question. Alright, so this was the last question I believe for the day today. And I hope all of you guys have learned something new or revised something new in this session. And yesterday I have also taken part 1. So if any one of you have missed part 1, you can watch it out. Both the PDF part 1 and part 2, dono ka PDF I'll be sharing in the group shortly after class. I'll be sharing the group. Part 1 I have already shared. Part 2 I'll be sharing immediately after the group. Okay. So thank you very much to all of you for attending and participating very actively. And in upcoming days, especially for our NEET PG and INICT student, the very first week of May, I'll be scheduling MCQ session that will be topic wise. So that will be effective for everyone. All of you guys can take part because your exam body is same for most of you. Clinical questions होंगे first week में हम schedule करेंगे. Usually in the night time I'll be meeting you for discussing those MCQs. ठीक है? अर्श गौतम, इस बार FMGE पेपर टफ होगा क्या सर? देखो, अगर इस तरह का कोई भी प्रिडिक्शन करता है, ऐसे लोगों से दूर रहना है ना. Nobody knows कि whether it is going to be tough or whether it is going to be easy, है ना. So ये बहुत ही absurd सी बात है. There is no such thing like that. In which group are you sharing? The Telegram group, you can search it out, and also in the Telegram group of Unacademy I'll be sharing that. ठीक है, चलो, bye bye to all of you, have a good night.